But thank you so much for attending. This is our third patient partnership week, and we think it's such an important week to celebrate everything that's going on in patient partnership. And that's both from the perspective of the Patient Association, but also from the perspective of all those fantastic organisations and patients out there that are working together to make services better for all patients and carers. Now, this is our third webinar of Patient Partnership Week. We've got a few more coming up over the course of the next few days, so please do register if you have not done so far, and we look forward to seeing you on those. So this particular webinar is all around health inequalities and social determinants of health and how that affects people with blood disorders and cancers. Yet, although that's quite specific to a group of conditions, we think that that could probably be kind of related to patients of all kinds and carers of all kinds. So when you're listening to everything that's being said, maybe just think about how this could be seen on a more general level. So social determinants of health, for those of you that aren't aware, are kind of the conditions in which people are born and where they live and where they work, and how these affect people's health and well-being. So an example is someone's education or their housing, or their financial situation, or their kind of social network. So what do those friendships and families look like? So that's the background. I'm Sarah Tilsed. I'm Head of Patient Partnership at the Patient Association. And today's speakers are Ram, John and Alfie, but I will let them introduce themselves. So I'm going to ask some questions to each of the speakers. And when I do, if you could briefly say who you are and then go on and answer the question that I'm about to ask. So we'll start with Ram. And Ram, you are a patient yourself, and it'd be really interesting for the audience to hear how you think health inequalities, social determinants of health, how they impact you or family members on accessing care. Thank you.
Thank you. Hi everyone. My name's Ram Paul, and I have a number of long-term conditions, pancreatic cancer, autoimmune, and a whole host of other conditions. I've both got personal experience of health inequalities and professional experience of my time, 30 years in social services, particularly working towards the end, working with colleagues in public health. I was responsible for a number of pension programs, particularly around vulnerable people and housing. The bit that and sometimes difficult to talk about impacts personally, so I'm going to try and shy away from that and focus more on just saying what the impact is in terms of from suffering from racism and the experience of public services and in this case in particular the NHS. Having said that, although it's been negative, but it's also been positive as well. So it's a mixed experience, but it does leave you, and I think other people will appreciate and understand this, just leave you feeling nervous about approaching services and what sort of response you will get. So that will actually have a number of impacts on you, make you unconfident, make you not advocate for yourself, which I think is a big issue, particularly for communities that don't get access to services anyway, due to structural racism. But I tend, because of my professional experience and my background, I tend to be a very positive person. So I do think that we collectively can actually change the health inequalities, although the challenges are huge because they're structural, but they're also personal, but and people that deliver services. So I do feel there are barriers, but they can be addressed through good practice and talking to people, working with people like myself who are willing to volunteer and work to address those issues. But there are also issues that I think the communities themselves need to address, and they can do that with the help from like the Patients Association and other bodies. So there's I mean, in terms of health policies, there's so much that needs to be addressed, in each area, whether it's housing, whether it's access to food, employment. They're all huge structural issues, but I think there's an awful lot of good practice in the community to try and address those issues, and with support, I think they can be done. I think I'm better at responding to questions in a particular field, rather than me talk about all this sometimes it's difficult.
Yeah,
I'll
no, I
leave it
can
there.
imagine. Thank you so much, Ram, and it's always good, I think, to really hear from patients what they're experiencing instead of just assuming that we all know best. So I think you did a really good overview of some of the positives and what needs to change. So thank you so much. And I'm going to go to John next. And if you could talk perhaps about the impact of social determinants of health on patients with cancers with blood disorders, please. Oh, on mute. Yep, still on mute.
There we are. Yeah, I'm always very slow to take my mute button off. So thank you, Sarah. Thank you also to the Patients Organisation for arranging today's Partnership Week. So it's a pleasure to be here. For people who don't know me, I'm John James. I'm the Chief Officer of the Sickle Cell Society UK, which is a national charity focused on sickle cell, which is a rare blood disorder. And in terms of impact, so let me, having introduced myself, let me just go to impacts, because I just want to support Ram in what he says about structural racism. Now, why I'm saying that is an impact, and I won't dwell on it, but why I'm raising it is that sickle cell anemia, which is a blood disorder and probably the biggest blood disorder in the country, so it is bigger than haemophilia, it's bigger than cystic fibrosis. The vast majority of people living with this condition are people of colour. They come from all over the world, but they are people of colour. And without question, there is good evidence, not evidence just from a patient organisation saying it, but from patients themselves and healthcare professionals who witness it, saying that this is a big feature in the care of people who live with this blood disorder. And I'll just illustrate it with an example. So if you have this condition, you have to attend A&E regularly with severe crisis. And to treat that crisis, you have to have morphine, ketamine, and lots of controlled drugs. And a lot of the time, people are stereotyped, saying, "Oh, well, look, you're back here. You're not really in crisis. You're here for another shot of morphine." So this stereotyping of young people, older people, male, female, is a factor. So I just wanted to illustrate that as an impact, because it supports RAM's view about this dreadful situation that some patients have to experience. And in terms of impact for the blood disorder that we deal with, it means that for some patients, they're reluctant to go to hospital or accident and emergency when things are serious. Now, just think about that for a moment. You are reluctant when actually you should be going to hospital, because if you have a severe chest crisis, it can lead to death, because of the negative attitudes or discrimination or stereotyping that goes on at the hospital. So that's the kind of first thing that I would say. The second thing about this blood disorder, and it affects other rare anemias and other red cell conditions in terms of impact, is that there has been research to show that over 60% of people who live with this condition live in what are classified as deprived areas of the country. So to Sarah's point, they will already be experiencing challenges with income and education and so forth. So it can feel like a double whammy. So this affects education. So children, by the time they're 12, will have had at least 2 strokes. It affects relationships, it affects work, it affects every facet of one's life. And the reality is that those impacts have been ignored by the NHS for decades. So for the country's biggest genetic blood condition has been underfunded, underserved, and you have to ask yourself, so a rhetorical question to the audience, well, why is that compared to some other conditions? And I'll let you come to your own conclusions rather than say anything about that. So these stark health inequalities have been a feature of people living with these type of blood disorders getting a lesser service than they should have received. And it's fair to say that we as a patient advocacy organisation have worked hard with NHS England and are working hard with the ICBs in some areas. ICBs are all quite different, but working with them to try and prioritise action to stem this tide of increasing health inequalities for this group that's been evident for some time. And later on, Sarah, I'll talk about some of those actions and what is happening. But I think, it's important for the audience to understand that, aside from the, structural racism, there are other health inequalities. So if you put that to one side, there are other challenges that this group of patients and families face. And our job, and thank you, you know, the Patients Association, is to kind of identify and you know, shine a lens on a condition that's been underserved. And by the way, it is well over 100 years that this condition has been known about medically. So it's not something that's just come up in the last, you know, it's a new condition, ultra rare and all of that. It's been known about medically, but it's probably the condition that has received the least amount of support and resources over those decades. So I'll stop there, and when we have the conversation later about what sorts of things are happening to kind of improve this situation, I will share some of the steps, and they're baby steps, but they are positive baby steps that are being taken by NHS England and some ICBs to address these health inequalities. Thank you.
Thank you. And I wish I could say I'm shocked and surprised to hear everything that you've just said, but unfortunately not. And we're doing a piece of work at the moment, and I should have mentioned this at the beginning, and it's been funded by an organisation called Bristol Myers Squibb, and we're looking at the health inequalities of people, blood disorders and cancers. And we've done a literature review, and we've done a focus group, and we've spoken to numerous organisations, including both of yourselves, and everything that both Ram and you, John, have said so far is what we're really, really hearing, and it is, yeah, quite shocking, quite shocking. So, Alfie, over to you, and about how do you think this is impacting on cancer patients?
Yeah, it's a really good question, and thanks to Ram for sharing your personal experience at the top of the meeting as well. So I'm the head of policy and campaigns at Pancreatic Cancer UK, but I also lead the policy for the Less Survivable Cancers Task Force, which is a coalition of charities that represent the 6 least survivable but most common cancers. So they're ones like pancreatic cancer, brain cancer, lung cancer. And we also have been funded to do a piece of work, hence why we're here today, I think, to look at the social determinants of health in relation to those less survivable cancers. But I guess just before I get into that, I think it's notable that for a cancer like pancreatic cancer, this 5-year survival rate is 7%, which is fairly shocking. And you know, you see that across the less survivable cancers that, you know, over the last 30-40 years, that survival really hasn't changed that much, and it hasn't improved, in contradiction to what we've seen in other countries, which means that there are systemic issues, which are meaning that, unfortunately, if you have a less survivable cancer, so cancer like pancreatic cancer, you're going to face additional barriers to survival and additional issues that are baked into the system as well. But I guess overall, social determinants of health are very relevant to cancer, and I'm obviously only here to talk about the less survivable cancers, but I think, you know, more and more research is coming out, including relating to cancers like pancreatic and lung, that show that the social determinants of health have a kind of causal link with your likelihood of developing cancer, but then also your experiences and your ability to survive it or not. And I think that, you know, I find it easy to get confused between social determinants of health and health inequalities. And when I think about it, and I'd be really keen to hear John and Ram's views and your views there on this after, but for me, when I think about social determinants of health, it's the kind of fundamental root causes of why you're well or not well. And then health inequalities is the barriers that you face in actually, you know, accessing that care. So there is more and more research, as I mentioned, that's pointing to the impact of, you know, for example, coming from a deprived area or a lower socioeconomic background and your likelihood of developing cancer or not surviving cancer. But there's also, obviously, once you then get to you know, trying to get a diagnosis, trying to get the right treatment at the right time, which for a cancer like pancreatic is absolutely crucial. Like any day that you're losing is a day that's going to impact on your survival. That's when, you know, if you're from one group, you might face additional challenges to another group. And so I think when we're looking at this area, we're trying to consider both, you know, the factors, the kind of wider factors and non-medical factors, with, I guess, particular consideration to things like likelihood of smoking, obesity, alcohol consumption in more deprived areas, and how that, you know, will affect your likelihood of developing a less survivable cancer. But then also we really need to better understand what are the barriers that people face from different backgrounds when they do then develop a less survivable cancer. So yeah, it's really great to be here and to talk about this further. I think for us, we're at the kind of beginning stages of this work. We're really focusing in on deprivation and the kind of modifiable risk factors around less survivable cancers for obvious reasons. But we also recognize that, you know, one of the biggest things that we need is better data, better overview of what's happening in the NHS now, so that we can understand, you know, if you're transgender, how is your care going to differ? If you're a person of colour, how is your care going to differ? But we currently just don't have any of that data in relation to how your identities intersect with the diagnosis that you might have. So yeah, really, really good to be here.
No, that was wonderful. Thank you. Sorry, who? I didn't see who.
It was John, Sarah. I was just going to say,
Yeah.
Alfie's analysis is really good about the social determinants versus the health inequalities. So
Was a bit
that's
just,
a
yeah.
very good way of describing it. And that's why, Alfie, I was mentioning for the blood disorder that we're involved in, it's a double whammy if 60% of people are living in what you'd call the social determinants factor of you know, cramped housing and so forth, and then have to deal with access issues or other issues when seeking services, feels to me like a double whammy. So thank you for illustrating it that way, Alfie. It's good. And just finally to say, I am with you 100% about better data for the kind of impacts on these conditions in the way that you described. So thank you for that.
Yeah, and you basically took the words right out of my mouth. I was going to say social determinants of health, it is a bit of a mouthful. And when we talk about social determinants of health and we talk about health inequalities, it can get a bit confusing. Are they different? Are they similar? Do they cross over? And as you were saying about that intersectionality, I think that's really important with how everything kind of overlaps with one another. So thank you for that. So we talked about,
Sarah, can I?
Of course you can. Please do.
I mean, I think Alfie raises a number of issues, which for me, it's a bit deja vu. I've been in the public sector for over 30 years, and I started off my profession in local government working on race equality issues, going back, you know, start from the 80s. And, you know, one of the things that kept on coming up was this issue about further research and data. While I believe that really is important, I think what shouldn't get prioritized is data over people's experiences, and I think we all know from existing literature, and there's so much of it, that we know what the answers are, and I fear that getting into the details and layers, and there are so many layers, that you could get you could get lost. And I was very frustrated at those times in the 80s, because my focus was very much working with the community, in the community, wider community, about how we address these issues and supporting each other. So for me, one of the areas that I've always taken away from my professional experience was around prevention, and that's why I choose to spend time with the Patients Association work, because I think they focus on prevention, they focus on good practice and moving forward. So while those debates are very, 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 very important, I'm just shouting out for developing the good practice and actually making a start, and I found that to really, really work even in local government, rather than talking about it, was to have a go. And you learn through having a go and changing practice, because as professionals we can get lost. I'm not saying anybody in the audience and people attending this seminar and presenting are lost, but my plea really from my experience, even small action has from practical experience, from my experience, small actions have a huge impact on people's health and well-being. And yeah, I'll stop talking.
No, that was fab, and I've been making notes because you've been saying some fantastic stuff there. And actually, maybe I'll come back to you first, because I feel that what you were saying leads very nicely on to what I was going to ask next, which was, what do you think now needs to be done? And you essentially started to answer some of that. What do you think needs to be done to prove access to care for people with cancers and blood disorders who are affected by social determinants of health or health inequalities? And some of the things I was thinking of, talking about this stigma and discrimination that is out there. How can we start to tackle that? And also more education of some of the conditions. As John was saying earlier, there's not that much awareness of sickle cell, and there really should be. So, Ram, over to you. What needs to be done to improve this?
Well, I mean, I think you cover it, and it depends on the particular area we want to focus on. But I think for me, the structural issues, which we talked about, but the prevention and the interventions is where I would like the focus to be on. Now, the intervention is whether that's working with the professionals in the field, or working with advocacy groups, charitable organizations, but also empowering the communities, because I think as if you look at the experience of what happened with COVID in terms of actually reaching out to vulnerable communities, and where that really worked, because there were a lot of barriers to people taking up the COVID jabs and etc. and trust, and because of our experience of racism, etc. Of going to statutory services. But when the services, the small services that exist were in the community, that they became the hub, and they were then able to reach out, because I think we need to do a bit more within the vulnerable communities as well, about raising their awareness of services, just like on the other side, the professionals, the practitioners, we need to raise their awareness as well. But the two things, if we could actually get the two dimensions to work together, like I think good practice around COVID examples showed us, there is a model there, I think, that we could look at.
Yeah, definitely. And actually, that's interesting that you mentioned about people looking at charities and communities, because we worked with British Red Cross, I think it was last year, the year before, and patients were telling us exactly this. We said, who do you go to, or what organisation do you go to for support? And all of them were saying, we go to our local charity. But the problem is, if you don't know about that local charity, then how do you know that it is there for you? So it was a really interesting conversation we had with them about that. And also, although it's great that people are going to charities, you know, charities are under resourced, so we can't rely on charities to be taking the brunt of perhaps services that NHS should be providing or the local authority. Anyway, now I'm doing the same as you, Ram. I don't want to be rude about it.
Well, I think you're totally right, but there are resources, and it's due to the structural inequalities that the vulnerable communities don't get access to the resources. But I know from my personal experience that the resources are in there in the NHS, and limited resources. I'm not saying they need resources as well, but there are limited resources. There are resources there with primary health, with the GP practices, and it's that, and I think there are obstacles there that we need to address, but there are also resources, and it's access to those resources that I think, which is where I'm, even though they're limited, but I think there's enough people there and there's enough good practice there that we need to use and to actually tackle these barriers.
Yeah.
Sorry, I'll stop there.
No, don't apologise, please don't. So John or Alfie, who should I go? We'll go with Alfie. What more do you think can be done?
It's a really good question, and I was thinking about it in preparation for today. And I suppose my perspective comes from someone who, I worked in the Department of Health during the pandemic, which, as you can imagine, was a real quiet time. But I suppose from having been on the inside and seeing how policy is made, I think that the way that we focus on the kind of the effects, the kind of latter bit of someone's journey. So the kind of, and I know we talk about this all the time, but the lack of focus on prevention, because it's hard to tell that story in a straightforward way. But if someone's already ill, someone's already in the system, then that's where the kind of prioritization is placed. I think if we really want to tackle social determinants of health, and one of the biggest things that I think we need to work through, and hopefully we'll see this with the new government, is that a lot of the interventions that you need are not coming from DHSC, they're not coming from NHS England, they actually need to come from the rest of Whitehall. And so how do you make that case compellingly? How do you work across departments to tackle, you know, something as kind of big as poverty across the country, because you know that that's going to have health effects. And I think from what we've seen from the new Labour government, what they've signalled is an intention to do that through the kind of mission boards that they're setting up, for example. But really, you know, from the research I've been doing in this area, to solve these as policy issues, both like health inequalities and the underlying social determinants of health, you need a really long-term approach. Like, if you're going to try and solve structural, baked-in systemic issues, that's going to take a decade at least. That doesn't mean you can't try and do things in the meantime, for sure. But I guess also you need an effort that's not just one bit of government, that's the whole of government, working with local systems, working with communities, working with people with lived experience in the charity sector. And it has been done. You look at somewhere like Sweden or Norway, and they've done a lot of work to look at the fundamental root causes of poor health outcomes, but that's not a quick fix. And hopefully we'll see a kind of wider strategic look at this. I know the last government was looking at health inequalities, but that didn't seem to translate as much into the underlying social determinants of health. And I think really, as this webinar is kind of reminding me, it needs to be both. We need to look at both if we're going to change people's access to healthcare and their abilities to live long and healthy lives.
I was smiling all the way through that, because with the Patient Association's manifesto, we wrote about we want health to be at the heart of government. So as I said, not just sitting within health, it needs to sit within education, it needs to sit within housing, it needs to sit within every element of society. Otherwise, we're not going to get that. So yeah, I couldn't agree more. Yeah. John.
Thanks very much, and thank you, Alfie, and thank you, Ram, for that great introduction about what can be done. I just want to add 5 things which build on some of the things that both Ram and Alfie have mentioned, and I think on the prevention issue, I think there is something about investment in more social prescription models of care that transcend health and social care and education and other bits, because that goes to Alfie's point about the social determinants. So I think there's more investment. Sometimes people don't look very favorably on social prescription models because they're not clinical and they're not, but I think they're an important point of investment that can add value to improvements for the communities that we are talking about. And so that's the first point. So I said 5 points, and I'll just go through them very, very quickly. And then looking at the chat in the webinar, just to build on Bob Farthing and Saadi Sharif's point about communication. And I think it's more than communication. I think it's communication, involvement and engagement by health of the communities that we are talking about. Really, really important. And I think Sally is giving some examples of a particular trust where she believes that communication and engagement is good. So the second point is all about communication, engagement and involvement of those communities in that programme of change. I think for blood disorders, and particularly for sickle cell, training of healthcare professionals, because it is remarkable that for the country's biggest genetic blood condition, that there are still healthcare professionals outside of the specialty who say sickle cell, oh, what's that? And that impacts patients when they are in pain, when they're in a medical ward. So training of healthcare professionals is really important. And credit to NHS England and the Health Inequalities team, they are doing that because they recognised that the consequences of somebody being admitted to hospital on a general ward or an outlier, as they call it, might be nurses and doctors not understanding sickle cell, which could lead to a preventable death. So that's the third point. And again, credit to NHS England, because as a consequence, Sarah, of some of the examples that I gave earlier on about the impact, we know, to Ram's point, and we don't need additional data to tell us that, we know that the experience of people in accident and emergency is appalling. So just so that you know, there's a nice guideline that says anybody with sickle who goes to A&E should get pain relief within 30 minutes. The evidence suggested that over 80% of trusts never met that. And that wasn't because of COVID. It's just been like that forever. So NHS England piloting an accident and emergency bypass unit where people, to test whether or not that might be a more suitable model for this blood disorder. It would only be a pilot over 2 years, which they will fund, but it will be in different parts of the country where there's high prevalence of sickle. So that's a positive. Why I'm using that is to say that's a positive example of actually we get it, we've listened, we know what the information is. We'll see if this this different model can work. And then the last thing to think about is whether or not, and this may differ, but whether or not there's any scope for digital to support some improvement for patients and families. And so those are the 5 points, Sarah. But actually, within all of that, this point about resources and investment, we all know that the NHS, indeed the country, is in a difficult place financially. So we've just got to think how resources are best used. But I do think that in some of this, it's about investing to save.
Thank you. And again, I feel like you helped me move swiftly on to the next question, because what I was going to ask was, do you know, or at least all of you, about any interventions or best practice out there that are actually taking place to improve healthcare for people? And some of the things I've been hearing throughout some of my work with this is targeting specific populations where the healthcare might not be as good, or really looking at transport schemes where people can't afford to travel to their appointments. And you mentioned a pilot scheme there, John. So is there anything else from any of you where you've actually seen fantastic pieces of work beginning to shape up, or actually are on the ground running?
Yeah, well, I'm very proud to mention one, apart from the... Do you want... Sorry, Alfie, do you want to go first?
No, you go for it.
You sure?
You sure? And then Alfie, then Ram.
Okay, all right. It's just such a lively conversation.
Yeah.
But in addition to the pilot that I mentioned, the A&E pilot, which is happening in London, Manchester, and Sheffield and Leeds, there's also a programme which is a social prescription model. It's run by people living with sickle cell, and they're supporting young people aged between 10 to 24 in a peer mentoring program, which has been recognised nationally. But the real benefits are for the individuals who live with the condition and are being mentored. And then the side benefit, if you can call it that, is that mentoring program, which, as I say, is run by patients for patients with the support of clinicians, not the other way round. The side benefit of that is those individuals who are being mentored have less A&E attendances, their bed stays or length of stay in hospitals are less, and so on. So there is not a cash release in saving, but there is a saving that can be financially quantified for the NHS. So, we're very pleased to see that. And that's why, Sarah, I was mentioning that, there are things like social prescription models and this peer mentoring program that can add value, importantly, to patients and young people, but also in terms of NHS efficiency.
Well, I'm a big fan of social prescribing. I think it's a great initiative. So I'm with you on that one. Alfie.
Yeah, also a big fan of social prescribing, I should say. I guess a couple relating to cancer specifically. So I think actually a really interesting and powerful national policy intervention is the smoking and the tobacco and vapes bill that we're going to be seeing come back in this parliamentary session. I mean, in itself, having talked about cost and savings, we know that smoking is a huge driver for most cancers, particularly lung cancer, for example. And so I think that's the kind of long-term approach that could really change change things, especially in more deprived areas where smoking is more likely. I think related to that, the targeted lung health checks that are being kind of tested and rolled out across the country are a really good example of using data and the available evidence to really focus resource in those areas where the screening is going to be most kind of impactful. So I think, you know, we'd really want to see those lung health checks be rolled out further. And then I guess to Bram's point earlier, and I think it's a really good one around not just, you know, waiting for government and the NHS to change things wholesale and give us a bunch of new research and evidence. At Pancreatic Cancer UK, we have a fairly distinct and unique problem, which is that people die very quickly, often with pancreatic cancer. And so we really have a fundamental lack of evidence about people's experiences, and particularly about the link between deprivation and pancreatic cancer. We assume there is a link, but we just don't know enough. And so we're trying to do the work ourselves to get to that answer as quickly as possible, because then we can go to the government and the NHS and make a better case for targeted interventions in those areas. But yeah, just to give a kind of illustration of the types of things that can be really impactful.
No, that's a really good example. Thank you. And Ram, are you aware of any interventions or best practice taking place?
Apart from the one I mentioned during COVID, how services could be got out to vulnerable communities as a model, I think that speaks to a number of areas that we talked about: investment in the community, investment in services, working in partnership. The other one, from my professional experience, that the program, it was a program that started under a Labour government under Tony Blair, was a program of a prevention program called Supporting People. Now, I think that is worth looking at, because that addressed a number of health inequalities and health and well-being issues with practical support. So I think it's a wonderful program to revisit, because it gives us a holistic approach to health determinants and inequalities in health. Finally, I just want, it's great to hear Alfie and what his organisation is doing. It just reminded me of getting information about people's experience and data to very early on in my career in local government in Sheffield City Councils. We recruited a number of local researchers, both victims and professionals. We empowered the community to go out and do the actual research and talk to the communities about their experiences, and I think that's a fantastic way of resourcing the community and getting the richer information from people's experiences on the ground. And I think that's I'm sure Alfie's doing that, but I think that's a good model that I think we should all practice.
I don't know if you want to respond to that or no.
Yeah, just to say, I absolutely agree. And I think it's, you know, the kind of data nerds need to do their job, but at the end of the day, we're ultimately here to make a difference for people. And so actually, this is a good example where we first had lots of conversations with people anecdotally, and, you know, unfortunately, there's just so little available information about pancreatic cancer that we then took those views, and that was the kind of start of the project, which is hopefully the way we should be doing things, is always starting with the person's experience and lived experience of care.
Yeah, Fabulous. I'm just looking through the chat and any questions that are coming through, and just thought something that might be, well, I wonder if you're all going to give similar answers or very different ones. I'm intrigued. So if you had to choose 3 things from each of you for what others out there can do, kind of takeaway actions, and this could be charities, it could be NHS, it could be government, it could be patients, what would you say your actions? And I'm going to go to John first.
I think for me the 3 really important things would be to, 1, engage the communities that you're trying to address the issues for. They must be an integral part of that process, whether you use them in the way Ram has just described in that example. But number 1, you must, and the thing about that, Rachel, is that the NHS has been good at talking to the groups and people that it normally talks to. It's not very good at talking to the groups that are more affected by Alfie's, description of both the determinants and the consequential barriers. So that would be the first thing. The second thing I would say is about training and of healthcare professionals, because the first interaction when it goes bad, and Ram talked about it, I talked about it, Alfie talked about it, poor experience has something to do with the interaction of healthcare professionals who, in all fairness, we know are under pressure at the moment for lots of different reasons. But I think there is a need to train and improve the morale of healthcare staff, because that can make a difference. And I think that there is a requirement for the areas that we're talking about, whether it's Alfie's area or my area or other blood disorders, a need for investment. And that investment, as I say, isn't about the begging bowl out. It's saying investment to save and make better use of resources. That's what I'm saying. So those would be my 3, Sarah.
I think they're a great 3.
Thank
So Alfie, what are your 3?
They are great 3.
Yeah.
I guess in addition to that, maybe I suppose this area is often seen as a kind of add-on, even if or a specific thing that needs to be done over here, which is a kind of amorphous, and B, we all have been talking about how it needs to be integrated into and woven into the delivery of healthcare. And so I guess I would encourage people to go back to their local ICB, Cancer Alliance, etc., and see where this work is happening. Is there one health inequalities lead in the ICB, and if so, how is that work filtering out? Because I think that partly the way that things are structured currently makes that more challenging. And then I guess, yeah, definitely involving people at the center of the development of this type of work from the outset, and also looking at kind of what's happening in other spaces, other countries, looking at what's worked. We don't need to reinvent the wheel, as what Ram was saying. You look back 20, 30 years and some of these conversations were already being had then. And yeah, I guess it's also about making sure that where we do have a proper view and there's been some real areas of underinvestment and under focus, how can we start to change that? That does need to happen at the national level, but the way our healthcare system has worked, we all have a part to play in that, and we can all think about, blood disorders, sickle cell, the less survivable cancers, and yeah, think about what we're doing in our local areas. So yeah, those would probably be my 3.
Perfect. Also a good 3. Very good 3. Ram, no pressure.
Well, no, I mean, I don't think there is much I can add now, because John and Alfie, I think have covered it really, really well. I would just say one comes to mind is for me, would be more holistic approach, and I would want to focus on prevention, because I think that means that it isn't necessarily a particular vulnerable community specific, but it applies across the board. And I think that health inequalities are structural and applies across the board. So for me, a focus around prevention while we wait for this investment to come through.
Perfect, thank you.
Thank you.
And we've got 2 more minutes to go, I think. So I've been scribbling notes whilst all 3 of you have been speaking, and there was some general themes that were coming up from all of you time and time again. So I just thought I'd relay back some of the things that you've been saying. So how patients are treated will affect how they then in turn relate to the system. So we've been talking about discrimination, and therefore they don't want to use the system, which is, I think, a big worry. We need better data, but don't prioritise this over people's experiences, which I think is such a fantastic thing. And then prevention, intervention, and investment is needed. Really looking at charities and communities and looking at that partnership model. And the example was for COVID, that worked particularly well. Communication, awareness, training of healthcare professionals, ensuring that these conditions are not an add-on, and it obviously involving people, that this work is representing patient partnership, which ties in well with the theme of this week, Patient Partnership Week. And I'm just going to end on something that Ram said earlier, which I just thought was wonderful. Just, small changes do make big differences. And I think, all of us are trying. And yeah, hopefully those small changes will make some kind of big difference. So thank you so much, John, Alfie, Ram. I think it's been wonderful. For me, it's been really, really interesting. I've learned a lot, and I hope it has for you as well. And yeah, I hope other people want to attend the other webinars this week. Hopefully will be as interesting as what Ram, John and Alfie had to say. So thank you again. Thank you.
Thanks, everyone.
Thank you all. Thank you.